Mandaki should join the Zoom. Good morning, everyone.
Morning, sir.
Hi, everyone. Hope we are online. We have already our today's chief guest, Dr. Prithpal Singh sir, is already there, and many of you are already there. I just shared the YouTube link also. Hope we will have a nice student CME. We are very proud at MPS-CDSIMER Center for Excellence in Training and Research. We have started various activities under this mutual understanding between Medical Pharmacology Society and CDSIMER, Dayanand Sagar University. So through this, various activities are planned in future also. We will be very much to host more programs like this. With this, just to give you some understanding about what is Medical Pharmacology Society, this is the society established in 2016, and various conferences, courses, and CMEs, webinars, workshops, books, like this, varieties of activities are conducted through Medical Pharmacology Society. Just to give brief about CDSIMER, the expansion is Dr. Chandrama Dayanand Sagar Institute of Medical Education and Research. It's a unit of Dayanand Sagar University. As all of you know, Dayanand Sagar University is one of the most reputed universities across India, and it is situated in Bangalore, and more than 40,000 students study in this university. So in this university, varieties of courses are conducted, including engineering, medical, healthcare sciences, various applied healthcare sciences, pharmaceutical sciences, and many more. You name a course, most of the courses are provided by our university. So now I would like to say that today we have aimed a very important agenda with the objective to share knowledge related to medical errors, medication errors. As all of you know, providing right kind of medication to right patient at right dose, at right route, for the right duration, and for the right patient. So there are so many rights to be ticked before providing the medication, and humans are bound to make mistakes, and they keep doing mistakes. And it's not a sin to make mistakes, but if you don't learn from the mistake, then it is not acceptable, and sometimes it is punishable also. It can be considered legally violation of practice, and it can be challenged in the court of law also. So with this important subject, nearly 15 days back, I received 5 students as the students to study medication error management at a tertiary care center as a part of their academic elective exercise. As all of us know, NMC, National Medical Council, started CBME curriculum nearly almost 6-7 years back, and continuously innovations happens in teaching methodology also. And most important innovation is this elective methodology of teaching. Here, students are given opportunities to choose their interested subject, some project kind of work, so that they get exclusive 15 days to go to that branch, study, understand, work, collect data, analyze, and come up with a report or a reflective writing that need to be submitted to the management. So when I received 5 students, you will be hearing them very soon. I have 5 enthusiastic students: Samiha, Pragati, Tasneem, Kusuma, and Danya. These are my third-year students, and when they came here, they were not having any idea about medication error management. And when I started the course, I thought, let me do my best efforts so that they will be made aware of at least what is the importance of this, and when they go back to their own subject or when they become doctors and start doing the services in the hospitals, at least they will remember this elective and at least take care not to repeat the mistakes that are already done, either by their colleagues or their by self, or if they have studied somewhere else. So with this objective, I started. Let me just play a small video so that will give you understanding about the activities that were undertaken all these 15 days. Hope that you will enjoy this video.
Causes of medication error.
Attitude in workplace.
Lack of knowledge.
Work pressure. Communication gaps.
Lacunae in standard operating procedure. Making error is a part of the human nature, but studying the errors and analyzing the root cause of the errors and preventing of the ADR and medication errors will lead to the better patient's outcome.
Error doesn't define our healthcare, but our response does. So, and every patient deserves excellence and not excuses.
So, medication safety is a shared responsibility. So, to help professionals, I would like to tell that we must adhere to the principles of safe medication administration. We should maintain clear communication and report errors without fear, and continuously update our skills about medication administration and errors. And to the public, I would like to advise that be actively involved in your healthcare, ask questions, and communicate your concerns clearly.
So, let's work together for a better patient's outcome.
Take care and avoid medication errors. Join hands to reduce medication errors. Medication errors study.
Medication error study.
Okay, so I think everyone should clap for them for the activities. What we, like you can see that if you go back to the kind of activities what we started, what we did, I think tremendous amount of work has been put since last 15 days. We started with the introduction and then we continued with the discussion, and I gave the opportunity for all my students to prepare, go through the literatures, go through the documents, go through the yeah. So go through the documents, go through the activities. That means go through. I gave literature and I asked them to go through each and every literature that is given, and then a few of them need to prepare for the for related to some study designs, and then some of them have to prepare through some theory topics. So like this, I gave the articles, they studied and they came back, and then I made them the presentation. They started showing, most importantly, what motivated me to take up all these activities are these students are very good. They are, whatever the activities I give, they do it very judiciously, and they are the force behind everything that is happening today. Okay, so they accepted whatever I say and they started doing it in that way. Like even they all motivated me that I need to think something extraordinary, and then we kept on doing, and then we did the walkathon where they all did their presentations, and then I did a course on statistics and data management also. So I trained them on that, and then I gave them that one task that they need to go to every ward and collect 2020 medication errors, active errors. They need to collect, and they have to come back and they need to tell me that what is the error, and that need to be documented, and that need to be discussed, that preventive strategies to be done. And then finally, like we also exhausted all the activities. Then we thought, okay, let us do one walkathon and rally. So that since only 5 people were there, so we thought, let us do the ward walkathon. So we went right from the casualty to we started from principal's office, and then we went to every ward, and all the corners of the hospitals were reached, and every nurse was reached, and then we told them that like we shouted slogans what you saw there. Prevent medication error. That was the summary of what the slogans were there. And then we did all this, and then finally, we thought that okay, we should do something more. Means they kept on observing whatever I give, they do it. Then finally, I thought this is the day where we should conclude this whole program with the student CME. And I told them that like whatever you have already presented to me, then you will present again to the whole world. Okay, so this will be recorded and this will be available in YouTube, and this can be one of the model of teaching for all others, so that this will be available for anyone who want to fetch in the future. So with this, I think I wanted to give you some update what all we did through last 15 days. And now let us pray Ma Saraswati for getting the blessings and to start our CME today, and then we'll start with the scientific program. And before that, I would like to say thanks to Dr. Prithpal Singh sir. Prithpal Singh sir, can you please switch on your video, sir?
Yes, sir. Good morning, sir. How are you?
Good morning, sir. Good morning. So, I can see that, one more important person, whenever I go back to sir, Prithpal sir, your video is switched off.
Yes. Okay, sir. Sir, it's on now.
Yeah.
It's on,
We're
sir.
not
It's
able
on.
to see you.
Okay. Sir, I think now,
No problem, sir. Okay. So
yeah.
what we were saying that whenever we go back to sir, suddenly like yesterday only I contacted him saying that sir, we are planning this. Are you okay with that? And I see that he is one of the most enthusiastic teacher, and being senior person, he conducts a lot of student oriented programs. So that's something which motivated me to contact sir, and he immediately accepted that he is available today and we can make go ahead with this senior CME program. And sir also accepted to do the anchoring means 30 minutes talk on medication error topic at the end of the students presentation. So this is the mixture of the practical activities, and then self study, and then presentation to the whole world, and then at the end Guru Dr. Pratibha Singh sir giving the gyan to all of us. So this kind of means I think a very fruitful program and well designed program. Hope all of you will enjoy. So let us take the blessings of Ma Saraswati, and then we'll continue our program. So let me just take, it will not take much time, just 1 minute for our Goddess. Okay, so with the blessings of Ma Saraswati, let us start the program, scientific program. And the first presenter will be Samiha. This is one. Amiha. So you will be introducing about error reporting and disclosure. Okay. So now you can start your. So you can do around. You can. Okay. So you can.
Good morning, everyone. Myself, Samiha Begum R. Good morning, everyone. Myself, Samiha Begum, a third-year MBBS student studying at CDSIMER. Today, my topic is error reporting and disclosure. So basically, error reporting and disclosure is mainly for the patient safety and the quality. The topics are the error reporting, error disclosure, ethical principle, about reporting system, barriers, and strategies for the improvement. So definition for error reporting is nothing but it is just a documentation or the communication of medical errors, adverse events, and near misses. It can be verbal or written, electronic or voluntary or mandatory. Error disclosure is informing the patient and the families about the healthcare errors, which includes explanation, apology, and the corrective action. The goal for this error reporting and error disclosure is improve the patient safety and prevent the recurrence of similar events and enhance the quality of healthcare. Importance of for error reporting is mainly the fundamental to patient safety and helps to identify the system failures, detects the hidden hazards, encourages the quality improvement. Near misses occur almost 300 times more frequently than adverse events and provide valuable learning opportunities. Reporting both harmful and non-harmful errors strengthens healthcare system. Now on topic on ethical principles. So healthcare professionals have ethical obligations based on respect for autonomy, beneficence, non-maleficence, fidelity, and veracity. Veracity is truth telling about what is happening for the patient. And benefits are builds trust and promotes transparency and encourages the accountability, may reduce the litigation through honest disclosure and apology. Error reporting mechanism is first the error occurs, have to report root cause analysis. Root cause analysis is the systemic investigations to find the underlying cause and the corrective action and improve the patient safety. Now we have voluntary versus mandatory reporting. Voluntary reporting is encourages the reporting of near misses, minor errors, confidential and supports learning, whereas mandatory reporting it is required by law that reports of deaths, serious injuries, sentinel events, and in this root cause analysis is performed. The examples for it is New York patient occurrence report and tracking system. It is done in New York and the USA. Whereas in India, Joint Commission Sentinel Event Policy and MedMax database. So basically, MedMax database is reporting about the medical errors so that to prevent the further occurrence of the same error and to improve the patient quality. Barriers to error reporting. We have individual factors and organizational factors. Individual factors, fear of blame, fear of punishment, fear of litigation, shame, and guilt. Organization factors like culture of blame, lack of autonomy, poor feedback, complex reporting system, and lack of standard definition. These barriers contribute to significant underreporting. Now I'll be talking about the error disclosure. Error disclosure includes informing the patient and family, explaining the event, apologizing, and discussing corrective measures. Benefits benefits are improves trust, increases patient satisfaction, reduces malpractice claim, and support a culture of safety. Patients generally want full disclosure of healthcare errors. Now, reporting versus disclosure. Coming to reporting, it communicates error within or outside the organization. It focuses on prevention and used for quality improvement. It can be internal and external. Internal means the nurses are reporting about the errors, and if it is on serious injuries or death, it should be informed to the government. This is the external. Disclosure communicates error to patient or patient's family and focuses on transparency used for maintaining the trust and patient-centered review. Both are essential components of patient safety. Now, the strategies to improve this reporting is non-punitive culture, leadership commitment, anonymous electronic reporting, education and training, root cause analysis, and timely feedback, standardized reporting form, encourage the reporting of near misses and multidisciplinary participation. Now, based on this research, so research shows several strategies that improve incident reporting in hospital. Around 90% nurses submit report. 85% is by electronic reporting. 80% is web-based system, and 75% is anonymous reporting. 70% is near misses reporting, and 65% will be the leadership involvement. So these are the research finding of reporting. So I'd like to conclude by reporting and disclosure are essential for safer healthcare. Errors should be viewed as opportunities for system improvement rather than individual blame. Open communication, ethical practice, and organizational support create a strong culture of patient safety. Every reported errors contributes to preventing future harm. The take-home message will be a strong culture of patient safety depends on timely reporting and honest disclosure of errors and near misses. A non-punitive system, effective communication, and continuous learning help prevent future errors, improve the quality of care, and build patient trust. Thank you for this opportunity.
Okay, Pitwal sir. Hello, sir. Pitwal sir.
Yes, sir. Yes, sir.
Do you want to make any comments, sir? Just 1 minute.
I think, sir, we can make the comment at the end, but
End.
it has been a very nice presentation by Samiha. Kudos to you and credit to you for taking up this particular error disclosure. And I think the take-home message was the most beautiful thing, that non-punitive action. I think that is what is most required at this particular moment, because the fear of punishment somehow denies reporting.
Thank you,
So
sir.
I think that was a good opportunity by you, sir, given to Samiha. And I think Samiha will take this particular opportunity and it will be an excellent learning opportunity for her. And I hope she does very well in her future. All the best.
Okay. Thank you so much, sir. So now we'll have Pragati. Pragati, come in. Okay, Pragati, you can go ahead.
Morning, everyone. Myself Pragati, and I'll be presenting on pharmacovigilance centers in detection and prevention of medication errors. So the contents include introduction, problem statement, pilot project, root cause, and
I think Pragati, what you can do is you can share your presentation.
Yeah, yes,
okay.
Yes,
Share the
sir.
screen.
So I'll be presenting on pharmacovigilance centers. Pharmacovigilance centers in detection and prevention of medication errors. So the contents include introduction, problem statement, pilot project, root cause analysis, prevention, summary, and conclusion. Introduction. Pharmacovigilance is the science and the activities related to the detection, assessment, understanding, and prevention of the adverse reactions or any other related drug-related problems. Pharmacovigilance, it provides data on adverse drug reactions, medication errors with the implications for patients' welfare and safety. Problem statement. In 1999, according to the US Medicine report, 2 air is a human. It showed that every year there were more than 1 million preventable adverse drug reactions in the USA, of which 44 to 98,000 were fatal and 7,000 were due to medication errors. Though the pharmacovigilance was globally more active in preventing the ADR and medication errors, but patient safety constitutes one of the main challenges to the pharmacovigilance. To overcome this challenge, a pilot project was initiated by World Alliance in collaboration with the Uppsala Monitoring Center, with the Moroccan Pharmacovigilance Center, so a pilot project. So to overcome patient safety, like main challenge, a pilot project was initiated by World Alliance in collaboration with the Uppsala Monitoring Center, with the Moroccan Pharmacovigilance Center as a project coordinator. The Indian National Pharmacovigilance Center, that is Indian Pharmacopoeia Commission, is located in Ghaziabad, UP. So in the next slides, we'll be dealing with the pilot project. The aim of the pilot project was mainly to develop the extended role for the National Centers of Pharmacovigilance and to collect the information on the incidents of adverse drug events and the medication errors, and to analyze the data at the international level and disseminate the findings. Among all the countries that were part of the pilot project, they received the reports from the healthcare professionals, but 19% reports were from the poison control centers and 40 were from the other organizations. They are pharmaceutical companies, drug information centers, and traditional practitioners. And 66% reports were from the patients. Some countries, they have started to work on improving the patient safety by incorporating the following 5 measures. They are improvements to the yellow card forms, the use of the root cause analysis. The yellow card is the report card that has to be filled or submitted when there is suspicion of any adverse drug reactions or medication errors. And then prevention of the medication errors and seminar on medication errors and retrospective analysis and establishment of specific databases for medication preventions. Among these 5 measures, we'll be dealing with the first one, that is root cause analysis, and the second one, that is prevention of the medication errors, in the upcoming slides. In Moroccan country, a retrospective analysis of the database showed that medication errors mainly occurred at the level of prescribing, that is 36%, and at the level of administration, that is 34%. And 40% of all the suspected adverse drug reactions were preventable. So, root cause analysis. It is one of the measures that was included by the other countries. So, this is a systematic investigation technique that looks beyond the affected individuals and seeks to understand the underlying causes for the medication errors. So, it is usually applied in a serious adverse drug reactions or a critical incidents, which are also known as a sentinel events. And this root cause analysis, there were several methods of conducting root cause analysis, such as Canadian root cause analysis framework, fishbone diagram, and Massachusetts Medical Society. All these methods, they have the same goals and they have the same concepts. So in this slide, we'll be dealing with one of the method, that is the third one, Massachusetts Medical Society, in the next slide. So this method, it has 4 steps that includes describing the event, identifying the proximate cause that led to the effect, and identifying the contributing factor that led to the proximate cause, and creating an action plan. So in Moroccan country, they had a
38 cases of tissue necrosis after administration of IV flucloxacillin. So among those 38 cases, 2 they had amputation of the limb. So to study about this case, they included the Massachusetts Medical Society method, and they found out that the IV flucloxacillin was administered without any diluent. And once they got to know this thing, they informed the doctors and manufacturers that the diluent has to be the part of the drug box and should be the drug should be diluted while administration. There are certain information that are derived from the retrospective analysis of the database that can be used in the root cause analysis. They are identification of the classes of the medications that are most often involved in the preventable susceptible adverse reactions, and the systems classes most involved in the preventable adverse reactions, the stage at which the error occurs during the therapy, the type of the error involved. So all these information that is derived from the retrospective analysis can be utilized in the root cause analysis. Then prevention. It is the second measure among the 5 measures that was included by the countries. So these mainly the duties of the pharmacovigilance centers in the prevention of adverse drug reactions and the medication errors. It includes alerting the healthcare professionals about importance of reporting and making them aware of the factors that cause them, and encouraging them to develop a safety culture that leads to enhanced awareness, and stressing the need for commitment among the healthcare professionals in preventing medication errors and improving the patient care. So pharmacovigilance centers, they aim to prevent medication errors by disclosing the information regarding the most frequent drug-related problems through monthly information bulletins in the healthcare professionals. To the profession. So this is a table where the following actions were taken by the Moroccan Pharmacovigilance Center when there is a detection of the medication errors in case of disease vaccination or the following drugs. Pharmacovigilance centers, they submit the results to the Drug Regulatory Directorate, which can submit the findings and propose solutions to the National Commissions of the Pharmacovigilance, which submits the outcome to the Minister of Health for a final decision. So final summary, we dealt with the introduction of pharmacovigilance and the main challenge that was the patient safety. To overcome that, the pilot project was developed, and the countries involved in the pilot project, they had a national pharmacovigilance centers, and the countries, they also included the following 4 measures, that is root cause analysis, prevention, retrospective study, and seminars. Among them, we mainly dealt in depth with the root cause analysis and the prevention measures. In the root cause analysis, again, there were 3 methods. Among them, we mainly dealt with the Massachusetts Society study. Conclusion. Pharmacovigilance centers can contribute to the detection and prevention of the medication errors. Collaboration between poison control centers and pharmacovigilance centers needs to be strengthened in order to improve the quality of the data collected and enhancing the patient safety. Thank you.
Okay, so thank you so much, Pragati. Excellent presentation. So as we understand, more than 1,400 AMC, that is the Adverse Drug Reaction Monitoring Centers, are there in this country, and we can really contribute to the safer medications. So to bring in the environment that every medication error is identified and causality assessment is done and preventive measures are taken. So as all of us know, pharmacovigilance identify the medications, these issues or the problems caused by medications. So if we can combine medication errors and adverse drug reactions monitoring together, and we can contribute to the safer medication use, and which can enhance the better patient outcome. Thank you. You nicely demonstrated the Massachusetts Society's study and told that one example, especially flucloxacin, where injection was given without diluent and amputation of the limb was done, which led to the loss of a limb and which could have been prevented. And that really eye opener, and I'm sure we can also discuss with the PVPI and see if we can extend the role of AMCs to the medication error management. Okay. So now next we will have Danya, the third year student from CDSIMER. Okay, then you can go ahead.
Good morning, everyone. I am Danya R, third year MBBS student at CDSIMER. So till now we dealt with the theory aspects of the medication errors, and now let us see some real life study designs on medication errors. I will be reviewing one such research article titled as Medication Administration Errors, a study of frequency and contributing factors among nurses working at a tertiary care hospital. So as we know, medication administration errors are among the most common patient safety issues in hospitals. This study has considered an operational definition to identify the medication administration errors, which goes as it is a disparity between what the patient got and what the prescriber actually wrote in the patient's file. It could be a disparity in the dose, drug, strength, time, a missed drug, technique, route, documentation errors of the medicine that occurs while the time of administering intravenous, intramuscular, subcutaneous, and peroral medication to the patient by the nurse. These errors can result in prolonged hospitalization, patient harm, and even death. So the common medication administration errors include wrong drug, wrong dose, given to the wrong patient, the drug given by a wrong route, the drug can be given at a wrong time, which comprises the maximum frequency of errors, that is 72.6%, followed by missed dose at 14%, and incorrect administration techniques. The objectives of this study was, firstly, to identify the frequency of medication administration errors among nurses, and secondly, to identify the factors contributing to these errors in a tertiary care hospital. This study was a cross-sectional analytical study which was conducted at Dr. Ruth KM, PFAU Civil Hospital and Dow University Hospital at Karachi from January to July 2018.
It was done. The study was done on a sample size of 204 nurses with more than 1 year clinical experience and a valid nursing license. The data was collected with the help of validated questionnaires and direct observation during medical administration. Through the study, it was found out that the frequency of medication administration errors was very high. That is approximately 81.9% of nurses committed at least one medication error. And this prevalence was higher compared to other developed countries and also was seen to be higher in the public sector hospitals. Based on the demographic characteristics, let's understand the statistics with a pictographic representation. When you consider the gender of the nurses, male nurses, approximately 52% of them made the errors, and females were 48%. And the age of the nurses, nurses younger than 35 years committed 82.3% of the errors, and 35 years and above is 17.7%. Education, nurses holding a diploma in nursing comprise 65.2% of error occurrence, and compared to BSc nursing, which was 34.8%. And when we consider the experience of the nurses who had less than 5 years of experience, the error prevalence was more, that is 47.5%, compared to who had more than 5 years of experience. This is the full statistical findings of the research article. So let's just break it down and understand it one by one. The factors that significantly was associated with the medication errors were, firstly, the working area. It was a strong association between medication errors and the wards where nurses worked. The highest error rates were seen in orthopedic ward at 93.8%, followed by surgical ward and the medical ward. So we can see here, the orthopedics ward comprised 93.8%, followed by surgical ward at 89.5% and medical wards at 87.9%. And this factor is statistically significant. As we can see, the p-value is less than 0.01. The next factor was patient gender. Medication errors occurred more frequently with male patients with 86.7% prevalence, which we can see here.
Don't turn that. Will come up.
So we can just see the patient gender, males 86.7%, and this factor is also statistically significant with a p-value of 0.045. Other factors which are not that significant but also are very contributing to the errors are the nurse age, educational qualification, years of experience of the nurses, nurse to patient ratio, time of medication administration, and patient age. So, as we saw in previously also, the age of the nurses, 25 to 30 age group, nurses in that age group, error percentage is 81.8%. And compared to gender, male nurses commit more errors, that is 86.8%. And experience, as I said before, less than 5 years experience had more error frequency. The nurse to patient ratio, when we see ratio of 1 to 10 patients per nurse, there is a more, more than 15 patients, there's a more error, that is 87.5%, followed by 1 to 10 patients. And then time of medication administration, we can see at 10 a.m., at around 10 a.m., the medication error occurrence is more, that is around 79.8%. And then the patient age, more than 18 years, a lot of patients errors are happening at 80.6%. Other contributing factors that are discussed in this study that amount to medication errors are heavy workload, nursing staff shortage, high nurse-patient ratio, interruptions and distractions during medication administration, poor communication among healthcare workers, inadequate pharmacology knowledge, illegible physician orders, inexperience, and carelessness. So all these factors, not only in this study, if we study in detail about medication errors in every hospital, we will find all these contributing factors. So these are really very important. And to conclude, I would like to tell that medication administration errors are highly prevalent among nurses in tertiary care hospitals, and the most important factors being working area and patient gender. So, strengthening staff training, improving nurse patient ratios, and promoting medication safety practices can reduce these errors and improve the patient safety. The authors have recommended certain measures to prevent these medication errors. Firstly, there is regular in-service training on safe medication administration should be given to the nurses. We should improve the nurse-patient ratio by increasing the manpower in the hospitals and encouraging confidential medication error reporting systems. A lot of web-based and reporting systems can be employed in the hospital to enhance in a smooth reporting of these errors. Then sharing medication incident reports for learning and prevention. These medication errors should be discussed with all other nurses so that one can learn from each other's mistakes. And further research into specific types and causes of medication errors should be done to prevent these errors. Take home message, I would like to give a message to the healthcare professionals out here that medication safety is a shared responsibility. As healthcare professionals, we must adhere to the principles of safe medication administration, maintain clear communication, report errors without fear, and continuously update our knowledge and skills. And to the public, I would like to tell that be actively involved in your healthcare, know your medications, ask questions when in doubt, and communicate any concerns to your healthcare team. Together, we can reduce medication errors, improve patient safety, and ensure better healthcare outcomes for all. Thank you.
Okay, so thank you so much, Tanya. I think it's not just theory that you keep on telling that there are errors are happening, but research studies also show that there are errors, and most important contributing factors are issues like one is work pressure, qualification issues, and the high amount of, especially 10 a.m. means you will see the high number of patient load during that particular daytime. And also age of the people, as they keep on aging, they will learn and at least they will get experience and qualification. Like we saw the diploma versus BSc. So the more rigorous courses definitely can reduce the errors. And also, it's not only we need to have that error-free environment. So regular training needs to be conducted, and patients also need to get involved. Public also need to get involved in ensuring that it's not only you can't make a clap without another hand coming from the other side. So both hands, one side from the healthcare professionals, other from the other side from the public also. They all also need to upgrade themselves and cooperate with the physicians, advisors, and doctors, nurses, technicians, pharmacists. Everyone should work like a team and then bring out the a safer working environment. And also, it's important for us to bring the fearless reporting system and encourage the people instead of punishing them, and implement more regular training. Highlighted, and you also showed with the evidence, right? Not that just a theory. So a research study also shows the same thing, and it can really help. Okay, thank you. So now we'll move on to the next presentation. Okay, so Kusuma will go ahead with her next presentation. Let us hear from her what is the message.
Good morning, everyone. I am Kusuma A. Nayak, third year MBBS student in CDSIMER. I will be talking about medication errors reported in the tertiary care private hospital in Eastern India, a 3 years experience. It is a review on research article. Medication errors are preventable events causing inappropriate medication use or patient harm. Medication errors can occur during prescribing, dispensing, administering, and monitoring. They can increase morbidity, mortality, healthcare costs, and reduce patient confidence. Despite the significance, underreporting of medication errors remain a major problem in India. So, primary objective of this study was to identify and assess causes and types of medication errors. Secondary objective was to study patterns of occurrence and to explore ways to improve medication error reporting systems. So this is a prospective passive surveillance study conducted from Jan 2016 to December 2018 in a 400-bed tertiary care private hospital in Kolkata. So the study included 50,822 admitted patients. Medication errors were reported by doctors and nurses. So, and the root cause analysis was performed for every reported error. Moving on to the analysis of the data, we can see that among 88 medication errors reported, 76 of them were administration errors, and 6 were dispensing errors, and 5 were prescribing errors. Based on categories of healthcare professionals, 91.6% were caused by nurses, and 7.2% by doctors, and 6.02% was from pharmacists. Age-wide distribution of medication errors, we can see there is highest significant frequency in 61 to 70 years of age, which is about 22 out of 88 errors. And in middle-aged 41 to 50 years of age, it is 16. Moving on to the gender-wise distribution, it is highly frequently seen in male more than females. So frequency of occurrence of different types of administration errors. When the administration errors were further analyzed, we can see that wrong dose administration was more frequent. It was about 28.9%, followed by 19.3% by omission of drugs, and wrong time, which is 18.1%. Followed by wrong medication 14.5%, and then we have wrong documentation 12.1%, wrong route 10.8%, and we have wrong expired medication and wrong patient, which both are 2.4%. Then, as we saw that underreporting is significant in India, we'll see the causes and strategies to improve underreporting. Causes of underreporting is mainly it is perceived as unimportant, and there is fear of punishment, no reporting if the patient is not harmed, reporting process considered as lengthy and time consuming. Strategies to improve reporting is to maintain anonymity, eliminate fear of punishment, digitalize reporting systems, use web-based reporting forms, regular training and awareness programs, increase pharmacist involvement. To conclude, medication errors are common but underreported. Administration errors are most frequent, as we saw. Regular training, active surveillance, and improved reporting systems are essential. Prevention of medication errors should be a priority for all healthcare professionals. Take-home message of this review on research article would be, to the healthcare professionals, I would like to tell, a reported error is a lesson learned. Every dose, every patient, every time. Safety starts with us. And to the community, I would like to say, your safety is your rights. Know your medicines, protect your health. Thank you for your attention and the opportunity.
Okay, thank you, Kusuma. It was a nice presentation. I think I saw that almost 50,000 plus patients were monitored, and I can see very few numbers of errors were reported, which is very it's very surprising, and also we can see that lot of underreporting is happening. We can directly see that patient physicians are not reporting, or the nurses are not reporting, pharmacists also not. And when we did a activity here, and almost 20 to 30% of errors cases when we saw will have small errors here and there. Can be dose is not mentioned, or capitals are not mentioned, or sometimes method of administration is not properly written. So like this. So out of like when we collected 100 errors. We collected almost, like even here, we can see that only even not even 100 errors are presented here. So it's a gross underreporting what we can understand here. So with due respect to the investigators, they have come out and told boldly that is completely grossly underreported. So it's very important for us to improve the reporting methodology. How we can improve? Most importantly, that like encourage the healthcare providers to be open when mistakes happen. Tell the come out and tell that we did the mistake, so this is the best. Maybe we can also assume that they might the hospital might have had the best working culture also. That is also can be assumed. So we leave the assumptions to keep them away. Keeping the assumptions away, we can always encourage the reporting culture, and so that we can bring the safe medication practices. Thank you. Okay, next we have our one more presenter, Tasneem. So Tasneem, please go ahead. This is your time.
So good morning, everyone. I'll be presenting on a research article which was based on medication errors in tertiary care hospital, which was conducted by Patel et al. So coming to the introduction, the definition itself says medication errors are any preventable events which lead to inappropriate medication use or patient harm, which can occur during prescribing, dispensing, and administration, which are major causes of morbidity and mortality and increased healthcare costs. Coming to the objectives of the study, the first one is just to improve the patient safety and quality of care, assess rationality of prescriptions, which is done using the FET case criteria, wherein it is scored in from 0 to 30, 0 to 14 are irrational prescriptions, and 14 to 24 includes the semi-rational, and 15 to 30 are the rationally prescribed drugs. And to evaluate the drug-drug interactions, drug-drug interactions contribute to the major medication errors because presence of one drug enhances or decreases the activity of the other drug. So a study was also done, and they also evaluated the drug-drug interactions using an app, a Medscape app, which categorizes the interactions based on minor, major, or severe. Minor interactions do not require any monitoring. Major ones require monitoring, and severe ones require medical interventions. And the objective also was to determine the nature and types of medication errors. So before going to the methodology, I would like to tell that based self-medications and also the patient demands on certain drugs for every symptom can also be a major factor for medication errors. And now let's talk about the methodology. It was a prospective observational study wherein certain set of patients were followed up for certain period of time, and an observational study was done. It was done in Civil Hospital Ahmedabad, and the duration was from October 2012 to Jan 2014 in General Medicine and Pediatrics ward. The sample size was initially 1,147 patients, but then it was reduced to 1,109 patients because certain patients were discharged and certain were shifted to other wards, and few of them died. And the methods included direct observation, wherein the investigator himself accompanied the staff nurses to monitor the administration errors or prescription errors. And the patient caregiver interviews are done, and reviewing of the charts was also conducted. Coming to the demographic profile of the study participants, out of 1,109 patients, medicine ward included the 511 patients, and the pediatrics was 598. Gender distribution, medicine ward males had more errors, and boys and pediatrics were had more errors. Age distribution, like in pediatrics, less than 1 year were more vulnerable because of decreased immune response, and medicine ward was like 12 to 32 years. The mean age was like 42.28 plus or minus 0.82 years and 4.5 plus or minus 0.67 years in pediatric ward respectively. Now, this is the main outcome of the research which was done. Coming to the prescription errors, these were contributing the major ones, wherein 262 errors out of 403 notified errors was done based on prescription errors. Improper medical history of the patient was also contributing a major proportion. Coming to dispensing errors, certain drugs which were also prescribed were not dispensed properly, so there was cases of omission. I would like to tell one of the case wherein a patient was prescribed to take atropine, and the dose of atropine was missed, and he was organophosphorus poisoning case, and the patient died due to drug omission. So, like, this can also contribute to the major medication errors. Administration errors, like certain drugs have increased bioavailability in oral or inhalational or IV forms, and the bioavailability decreases if the route is changed. So inaccurate dose or wrong route administration can also contribute to medication errors. And wrong patient, like patient should be proper before prescribing the drugs. Coming to the common drug groups which are involved, antibacterial and GI diseases contribute to the major drugs which involved, because majority of the patients come to the hospital cause of infections. So antibacterial drugs contribute to the major ones, and then we have cardiovascular, intravenous fluids, and others. Now let's talk about the drug-drug interaction, wherein out of 1,109 prescriptions which were done, 46%, that means 508 of the drugs prescribed had drug-drug interaction, wherein 53% were non-significant and 38% were significant, and 9% had serious complications, which had to be clinically observed and had the potential to cause severe medication errors. And coming to the types of medicine administration errors, this is majorly done by the nurses in the medicine wards, wherein we have one of the patients who had pneumonia was wrongly administered calcium. So wrong patient and wrong treatment plan was done. Coming to the wrong route administration, zinc, ranitidine, paracetamol, like they had conversions from oral to IV or IV to oral or tablet to syrup. And we have errors in dose interval, wherein ceftriaxone, comoxiclav, metronidazole were like either given early or given late, and inaccurate dosage of drugs like comoxiclav, salbutamol, enalapril was also seen. And drug responsible for major of the drug-drug interactions were like enalapril, pyrosemide, and atenolol. And certain GI drugs like ondansetron was like seen to be noticed to have nine interactions which contributed, but then they were not significant, so they were kind of ignored. So we can see hyperkalemia is seen with aspirin, with which reacted with spironolactone, digoxin, or spironolactone reacting with digoxin. It is by pharmacodynamic action. And we have certain like lipidemic drugs like atorvastatin and spironolactone, wherein spironolactone decreases the level of atorvastatin by pharmacokinetic action. And we have enalapril and aspirin, as I told you, like it increases the renal toxicity. And we have atenolol and amlodipine, which increases the hypertensive effect due to pharmacodynamic action. This was rationality of prescription was by Fatke's criteria, wherein 53% of the drugs were semi-rational, and 16% were rational, and 31% were irrational. So to conclude, I have discussion and implications, wherein pediatrics patients like less than 1 year were particularly more vulnerable. Antibacterial misuse may promote antimicrobial resistance, and regular monitoring and prescription audits are really important. And IV associated with majority of the errors, and medication errors are common in almost all the wards. To conclude, I have medication errors occur at each and every stage of medication use. and significant drug-drug interactions and irrational prescribing remain concerns. Out of the 100 admissions which was there in pediatrics ward, 6 of them out for like every 100 we have 6 medication errors which occur, and in general medicine ward for every 100 admission we have 5 errors which can be noted. Coming to the recommendation, I would like to tell that computerizing prescribing process is important because it can help in monitoring, and like for data reviewing it helps a lot. And education of the healthcare professionals is also important, and establishment of medication error reporting system is important because we need to encourage error reporting so that we don't repeat the same mistake again. And implement drug use policies for safer patient care is also important, and conduction of regular prescription audits is important. So before concluding, I would like to tell medication safety isn't a delaying procedure or it isn't an extra work, but it is a right work to do because patient safety is first, which we need to prioritize first, because patients trust our hands, and medication safety ensures that we are trustworthy. Thank you.
Yeah, thank you so much. Thank you so much, Prashni. Yeah, you discussed the other, part of the this medication error aspects. So we always talked about the errors committed at the prescription or the age, training, and all those things. And you talked about the very important aspect of the pharmacokinetic and pharmacodynamic drug interactions and some of the deleterious and harmful effects. That's the another most important responsibility of the medically qualified pharmacologists, who are considered to be the knowledge bank, and who should be very strong in the theoretical background and understand what about the pharmacokinetic interactions, what about the drug-drug interactions, like pharmacodynamic interactions, and it can be related to even pharmacovigilance related activities, like where there is a severe number of adverse drug reactions are happening, and it's very important for us to identify and ban them as simultaneously, continuously, like where the way how we can see that pantoprazole was promoted when and ranitidine is demoted, basically. Like earlier we used to have ranitidine and its related products more frequently used for treating the peptic ulcer disease. And when we started seeing that there are some evidences that polyposis or some kind of cancers that happens in the esophagus after using these ranitidine and related drugs. And nowadays, we have better and safer drugs like PPIs, and people are promoting that. So similarly, like if we keep on observing and over a period of time, and when we evolve with better group of drugs and more cost-effective drugs, and we should be able to, like when we compare the cost versus the toxicity and saving the patients, and definitely we can, consider the, cost, little bit of addition cost if we can prevent a cancer. So why not do that? So like that, like we can always promote the better practices and improve our guidelines, and all these can happen mainly by identifying all these medication errors, pharmacovigilance. When all of us work together and deliberate, this kind of discussions what we are doing today, this kind of discussions should happen regularly. And when we do all this, I'm sure there will be more knowledge exchange happens, and we will come up with the better guidelines. Thank you so much. It was a very nice presentation. Now, we have ended our students' presentation, but the program is not yet concluded. So now we have come to the very important part of the discussion. We will have we have a very important guest lecture by our chief guest, Dr. Principal Singh Matreja sir. He is currently working as the vice principal and professor and head at the Tirthankar Mahavir Medical College, Moradabad, under Tirthankar Mahavir University. So we are very fortunate to have him. Before handing over the mic, let me introduce sir. So he is a very scholarly person and very motivated and very enthusiastic person. And we are very fortunate to have him today. So let me introduce sir. And then now we'll move on to the next stage of our presentation. So let me just give a brief overview of Sir's achievements, so that it's always important for us to celebrate the our today's important person. Dr. Prithpa Singh Matrija sir is the Vice Principal and Professor and Head at the Tirthankar Mahavir Medical College and Research Center, Tirthankar Mahavir University, Moradabad. And he is a very well-read and well-recognized researcher with more than 125 publications. He is the author of textbook on pharmacology and lecture notes in pharmacology, contributor for many books, some chapters also. And then he has done so a lot of research, and also he secured research grants from Tuberculosis Association of India and ICMR also. And he actively involved in clinical trials conducted by various multinational trials, multicentric trials, and also he is a very sought after, guest lecturer nationally and also internationally in various aspects, including rational drug use, clinical research, and medical education, wide areas. And sir is a highly accomplished member of various professional bodies, including Medical Pharmacology Society and SOPI and so on. And then he is the founder member of BMSA Society, and then editorial board member of various journals also, like he is the editorial board member at the Clinical Research, Education in Medicine Journal, American Journal of Health Research, Clinical Research Journal, and then is the associate editor at the Journal of Medical Education Research Ethics. And then he is the coordinator of, he is also, highly responsible person at his institution as a coordinator at MEU and chairperson at the Animalities Committee, and again member secretary at the Clinical Research Center, CRC, and then IEC. So some of the other universities also call him to be a member of ethics committee and also safety board, and he is the co-coordinator of Adverse Drug Reaction Monitoring Center, AMC, and also Material Vigilance also. So he is also PhD guide. Thank you so much, sir, for accepting to be part of today's program and encouraging our students. Now the stage is yours. Please go ahead. And your presentation is very important, because whatever we learn from the students, now the highly experienced senior person is going to talk about what is medical errors and what are the common causes and how we can prevent them, and this will affirm what our students have talked till now, and we will be very happy to learn from you, sir. Thank you. Please go ahead, sir.
Thank you so much, sir, for the wonderful opportunity. So at the outset, I would like to thank you for keeping me as a part of this important activity, that is the presentation of the students. This is one of the best parts that I like about students, is when they learn and they express themselves, and when we give them the opportunity to express themselves on a national platform. That is a wonderful experience and a true learning experience for all the students. So before I go into what I am going to talk about for the next half an hour or so, prior to that, I would like to talk about the presentations that have been done previously by the students. So the students have done wonderfully. They have done a lot of hard work.
Can you please increase your volume, sir?
Yes, sir.
Can you please increase your volume?
I'll do that, sir. Yes, sir. Now is it fine?
Increase your volume, sir.
Now it's fine, sir. I have increased it to the maximum. I have increased it to the maximum, sir.
Please go ahead, sir. Please go ahead, sir.
Okay. Okay, sir. So I think when we talk about the students, I think it is a wonderful platform for the students, and all of them have done exceptionally well. Specifically when we talk about all these presentations as they went ahead, apprising everyone about a research article itself gives them a lot of experience. Maybe this experience they carry forward for their post graduations also. And one of them was talking about pharmacovigilance, and there she also discussed an important part about medication error. Truly, medication error is a part of pharmacovigilance, not only the adverse effects. So why are we talking about medication error? And that is where I'll start my presentation on. So now I believe this is one of the particular pictures that was circulated in various social media posts, and I believe I don't need to say anything out here, and everything is self obvious. There is one brand, that is Medzol. Medzol is available as an antifungal, as an antiemetic, as a PPI, as an antihelminthic, and maybe also as a benzodiazepine. So this is something that is waiting to happen, a disaster in the process. So there are many more tricks like this, there are many more things like this, and this is where we start our presentation. So what is this medication error? So when we talk about a medication error, this is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of healthcare professional, patient, or consumer. So these events may be related to your professional practice, healthcare product, procedure and system, even the product labeling, packaging and nomenclature, dispensing, distribution, administration, education, and monitoring. So almost all you find everyone fits in almost all the roles. You are there, as students highlighted that the nursing staff was there who was dispensing the medication. Did you give them proper uh, the directions how they have to go ahead with that? So that could be one of the reasons why there was an error as reported by few students in their studies, that the research articles that they quoted. But I don't know why, because we didn't exactly go into the exact details of what these papers were meant for. Now, this is one aspect that I always keep in this. Now, this is something that has been there, and maybe this gives me a memory of a airplane crash that happened last year, where a plane crashed on. It was specifically we remember this because it crashed on medical college, and few of the students who were there in the mess they were taking their meals, and most of many students died in that particular crash. Now, were you ever told about this, that this is what an airlines expect? All the airlines, they expect that 1 to 2 jets will crash daily. That means that they are expecting somewhere around 1,000 deaths weekly. So let's paramount it to the number of weeks that are there in a year. So from that comes out to be somewhere around 52,000. Why is this figure so important? Let's move to the next page. So when we are talking about 52,000 deaths only in a plane crash, look about what is happening when we are talking about the deaths occurring due to medication error. Somewhere around 44,000 deaths to 98,000 deaths annually. This is not the data of India, this is data of US, where we have a robust system which tells us how to go ahead, how everything is being monitored and everything is being recorded. Most of the time in our country, many of the things are not recorded, maybe due to lack of awareness or whatever could be the reason. So let's see what exactly this is. So how you talk about medication error again from US, not from our country. The number of deaths associated with, let's say, the leading cause of death, maybe myocardial infarction or cardiovascular related disorders, cancer, stroke, lung disorders, accident, and then medication error. So that means that this is the 6th leading cause of mortality in US. It could be more than that. It could be less than that in other countries, depending upon the robust system of reporting. What could be the reasons? Reasons could be verbal orders. I have some examples. I'll be going to these examples and then let's have what you exactly feel like. So this could be due to verbal orders. This could be some poor communication. Obviously, this was also highlighted in the presentation by the students. It could be a poor handwriting because all of us know that doctors are famous for bad handwriting. It could be due to improper drug selection. Where one of the students pointed out that around 31% of the drug prescription were irrational drug prescriptions. It could be due to some missing medication. Again, I go back to the presentation of the students. One of them said that atropine was missed in OPC poisoning that led to the death of the patient. It could be due to incorrect scheduling, polypharmacy, where you have multiple 4 or 5 drugs are even more being given. Drug interactions, just recently the last presentation had been on this. Availability of flow stock where there is no second check. LASA, which is look alike, sound alike drugs, which I just started with. That is LASA, look alike, sound alike, where we have drugs with a similar name. Hectic work environment, obviously this was there at one of the studies that there was work pressure and all those things, and lack of computer decision support. That means that there is not a robust system of working environment that is there in the country. So various factors that contribute could be human related, system related, or medication. Let's go through each one of them one by one. So when we talk about the human related factors, it could be due to the providers. I believe this is what most of us have been hearing right from the beginning of this particular process, overworked. But I think one of the things that we did not look into was undertrained. And when I talk about undertrained, I can go back to one of the presentations again to the student where she said that the nursing staff who had more than 5 years of experience had lesser medication error as compared to those who were newly trained. The competency, they were distracted, maybe they were having illness or they were stressed out. For the patient, it could be that the patient was in a hurry. Patients are quite busy these days. They do not have time to go to the healthcare checkup unless it's too late. The health literacy level, obviously not everyone is educated enough, and the social media has added to the problems of the doctor. They do not understand the medication use. This is one of the major reasons. How often have we seen our physicians giving directions to the patient to how to take the medication once they get the medication back to them? I think because that is again because of the overworked environment that we have. And they also trust providers that they will not make mistakes. Now let's see what has happened. This is something, a typical case scenario that I will talk about. Now let's talk about this particular scenario. There's a particular ward, and what happens is the attending consultant tells the resident, obviously the postgraduate resident, to give patient free water. So now you will analyze how things are happening. So that what we meant was that allow patient to have or to consume water or drink water. Now the resident did not question. He assumed that it was meant an IV free water and writes for free water to be given IV. Fine. After here, there's no problem. Now he has written these notes, give IV water in the free water in the file. Now this registered nurse could not find free water, IV free water from the pharmacy. So what she does is she calls the pharmacy asking where they could get the free IV water. Pharmacy says we do not have any preparation like this, no further questions, and tells the registered nurse that they could get them from the central store. The registered nurse obtains IV free water from the central store. So again, the central store also does not question why she is asking for registered nurse, and why and in that particular water that she obtained, it was written water for irrigation. So this, but now this what the registered nurse done. She attached that this water for irrigation bag to the regular IV tubing and infused 600 ml of treatment. So this is going on. Now there's a change in shift, and I know there's change in shift. Now what comes next? After the change in shift, an experienced registered nurse, that means with a training experience, she notes that the patient is lethargic. She observes the bag of water, she removes it and calls the consultant. So what has happened is, why patient is lethargic is this free water has no electrolytes and could have caused the RBCs to burst up, and then agar this registered nurse did not see this, she did not stop it, it would have resulted in death of the patient. Now, what was wrong, or what should be done? So according to all of you, let's have it in the chat box. I'll wait for you. Who is wrong? Who is wrong in this? The registered nurse, the resident, the MD, who is wrong? Can we have some answers in the chat box? I've got one of them. All three, okay. Any more options anyone would like to go for? One more. All of them, okay. Okay. So let's have now this. Now the consultant used an unfamiliar term, that was free water. Obviously, he meant patients drinking water. But then there is a problem. How often do we take care of this, that whatever we are trying to convey, was it conveyed, and was it meant similarly to the person whom we conveyed it? We don't check it. The resident, he did not clarify, so he assumed that this is something, because the consultant is senior as well, this is something, and he assumed that it has to be given by the IVU. So the registered nurse, she was good enough, she wanted to help the patient, so she went out of the way and tried to obtain, because now the doctor has written free water, she tried to obtain the free water from everyone. She tried to go to the central store, she tried to go to the pharmacy, and then finally she got the free water from the pharmacy. But again, the question is, no one, neither the pharmacy nor the central store even asked her what was happening. The pharmacy technician didn't identify herself as attacked, didn't ask why the registered nurse had this unusual request, didn't consider having pharmacist consent with the registered nurse. Similarly, the central store staff, we never questioned registered nurse why pharmacy was not involved, providing drug directly to registered nurse without normal pharmacy process. So we were talking about three of them. Now there are two more people who are involved in this: the pharmacy technician and the central staff. Now this is something that is related to the humans. Now let's talk about the system-related factors. In the system-related factors, we talk about there's a clear lack of communication, obviously, which you could see out here, poor workflow, disorganized workspace. Now, obviously, it is always said, if you are organized, everything comes in place. If you are disorganized, you are bound to commit error. There is inadequate tools to complete work, and obviously there is lack of supervision. There could be medication-related errors. This medication-related errors could be for LASA, that is look alike, sound alike. Now, why I'm repeatedly telling you about LASA, because this is one word which you will hear now, because you are all up there, many of the students are there, so they will be hearing this term. So it's not like this is an alien word that is coming up. LASA is look alike, sound alike medication. And then there are multiple dosage forms and strength. Now look into this. Another, we were talking about multiple dosage forms, both same drugs. One is 20%, the other one is 25%. So the staff has to be aware what is the strength available, what are the different combinations, and what is meant, what he or she wants to go with. So medication errors could include prescribing errors, dispensing errors, medication administration errors, and patient compliance error. I believe already all of this has been covered a lot, but still we'll be talking about some of them. Prescribing errors, obviously, what happens is NNC comes out with a rule that there should be generic prescribing. Maybe we don't have a generic setup in our country that exactly the setup that is required in that situation. So there is a problem with the generic drug industry. So that is gone. Then they say go for capital writing, because what happens is if you don't go for capital words, I repeatedly said in my class also that agar aap repeatedly if you don't write capitals, you are at the mercy of a pharmacist. Obviously, a pharmacist is less educated than you. He has a lesser knowledge as compared to you, and you are responsible for it. So, the prescribing error could be you could go for an incorrect drug selection based upon indication, contraindication, known allergies, and all these things. A dose could be incorrect, dosage form could be incorrect, already has been highlighted. Quantity, route, concentration, rate of administration, or instructions for use of a drug ordered or authorized by the physician. Ineligible prescriptions or medication orders that lead to error that leads the patient. Then there is another thing that is omission error. Omission is you tend to omit something, and that is that you did not follow as ordered. So failure to administer an ordered dose to a patient before the next scheduled dose, if any. So obviously there should be a habit, whether you are in a hospital, that you should check the files, and maybe you should have a robust system in place that okay, this dose is done, the next dose should be there. So we cannot say that we just don't keep our records and everything fall in place. No, we have to have a record, then only we could be able to appreciably suppress medication errors. Now, what is this omission errors that has been seen in nursing home? And these are certain studies, and these are the references of these studies. So what they found out was in patients more than 65 years of age who had CHF, 62% of these patients were not prescribed ACE inhibitors or ARBs. In patients with MI, 60% of these patients were not prescribed aspirin, 74% were not prescribed vitamin. In stroke, 32% of these patients were not prescribed any anticoagulant or aspirin. In patients with osteoporosis more than 65 years of age, 51% did not receive any treatment. Patients with depression, 45% with no treatment, and patients with pain, around this number is very vague because perception of pain is different. So around 20 to 55% of patients had uncontrolled pain. Then there could be wrong dosage form error, where obviously it suggests that the dosage wrong dose was administered, maybe a higher dose or a lower dose administered. Wrong drug preparation error, maybe the formulation you want to just before the injection prepare that drug, you prepared it 2 hours prior. Okay, my work will be. This is what we see. Normally, we see the nursing staff preparing all the injections at once and then going and putting all the injections to the each and every bed. So that is a wrong practice. Obviously, that is a wrong practice because you don't know. Then you are having multiple injections, and then you might be confused what injection is going where. So obviously, that is there. Wrong administration technique error. Obviously, inappropriate procedure or technique could lead to, and deteriorated drug error. I think this was one of the points that was mentioned, that administration of a drug that has expired or for which the physical or chemical dosage form integrity has been compromised, that particular drug is being given. Monitoring error, that was what we saw. Failure to review a prescribed regime for appropriateness or detection of problems, or failure to use appropriate clinical or laboratory data for adequate assessment of patient response to prescribed therapy. Compliance, obviously there is a part of error on the patient aspect also. Not every time it is the physician or it is the healthcare team that is involved. That is why I believe the students that they were presenting, they said the role of healthcare professionals, the message for those, and the message for the public. So inappropriate patients' behavior regarding adherence to a prescribed medication regime, other medication errors that do not fall and they do not have any category, they could be multiple. Now let's talk about few more studies because we have been having 3 studies. So this is another study that was somewhere around in 2000. I don't see medication error studies these days, but all of them are previous. So in this particular study, this was a 12-month observational study. There were 18 participating nursing home, around 30,000 nursing residents were involved. And all of them, they were around 546 drug treatments, maybe underreported. That was around roughly 2 per 100 residents per month, leading to 1 fatality, 6% were life-threatening, 38% were serious, and the drugs that were involved were antipsychotic, antidepressant, sedative hypnotics, and anticoagulants. Obviously, there is in the studies that the student presented, one of them they said that the antimicrobials were also involved for drug treatments. Then in 2005, a Goodwin study estimated 8 lakh medication errors or 800,000 medication errors. Again, Barker reported average errors for around 12.2. So you see 1.89 and then out here. So 44.8% were non-prescribed drugs, 11% wrong drug, wrong prescription. So now this is a concern for our country also. Over-the-counter medications without prescription, some dietary supplement or health supplements, all these do add up to medication error or drug-drug interaction. So what are the essential components for a learning culture? Because obviously it is not one particular thing that can be taken up in one day. It has to be taken up over the years. It has to be a team effort. So some of the essential components that has to be there is you have to build a trust. You have to encourage reflections. Now, encourage reflections is something totally different from what was said as non-punitive action. So, reflections is what you feel you should have improved. So, maybe this could be an open forum where you could talk about, okay, this is the thing that I would like to improve further. This is what went wrong. And I think I would take care of this in the next particular situation. So, based on your reflection, there are more people, there are 10 people in the team, they also tend to learn, okay, this was one thing that is not to be done. So now, apart from being one person being trained, now we have 11 people who are trained for this, that this particular drug or this particular interaction should be taken care of. Demonstrate learning values, enable knowledge sharing, empower employees and formalize learning as a process. So sharing the learning. So I've already told you near incidents and near misses need to be timely, the sooner the better, and it should be repeated at every. So there has to be a reinforcement. So this reinforcement could be from individual patients and patients' feedback, cluster reviews, themed newsletters, presentation to services and division, annual reports, or there could be national reporting, litigation claims, and NHS resolutions scorecard, whatever facilities are available for a particular institute. Now there are many factors. Again, this is one of the things that many factors tend to influence the use of medication. So these are the intrinsic factors, the societal values, the work group where you're working, the workplace, and the information. Normally, if I talk about the work group, whatever your head is prescribing, most of the listeners tend to follow the same path. Whatever, and then in the workplace, what is the amount of workload that would again determine how it goes. How aware you are for your various drugs and drug-drug interactions, that is another important point. Your prior knowledge is an important aspect. Be prepared, be learned enough, and then you have to respect the societal factors that will come into the picture. So all these things tend to influence your practice. And when we talk about how to go ahead for a good prescription or a rational prescription, the first thing that you need to do is define the patient's problem, specify your objectives, verify whether your pre-treatment is suitable for this patient or not, start the treatment, give information, instruction, and warning. Just writing the drugs will not be sufficient. further when this patient needs to take this medication, any advices that you would like to give to this particular patient, any precautions that you would like to, any special foods that this patient has to avoid, monitor, and then you call up the patient for the follow-up, you monitor the treatment and stop it. All these things do come into a model of good perspective. So I think we have already talked about this, and I think we have been clear about this. I'll just once monitor how we monitor and stop the treatment. You have to monitor whether you need to continue or stop the treatment, and then so I think sir has already been telling you about this right in the beginning of the session, that you have 5 rights: right patient, right drug, right dose, right route, and right frequency. And if you look into these rights, a medication error will be avoided. So when we talk about what take-home message I would like to give you, the take-home message that I would like to give you is that it is our duty to provide healthcare for mankind through rational approach and providing rational management as part of overall rational patient care. So the highlight out here is the rational word. So with this, I conclude my session and I hand over the baton to Shivamurthy sir for further proceedings. Thank you, sir.
Thank you so much, sir. In a short time, you have done the excellent job by putting across the nice presentation, and it was really we are very fortunate to have you today on this call, and it's really nice that we have a very nice gathering here, and the purpose of the meeting and the kind of the objectives completely achieved. The whole elective, we got a very nice meaning for the complete what we wanted to do, what we wanted to achieve is completely fulfilled. I can say it happened mainly because of you coming online and joining us today.
No, sir, I would disagree with you on this. It is mainly because of the students' initiative.
Yes, sir.
The precursors for this are the students.
Yes, sir.
And if they don't come up, we are nowhere we stand.
Yeah, I agree with you. Actually, I also agree with you in this part, because like students who motivated us to take this to this extent. And now I would like to call upon our students also, like can you all of you come here and show together our come here.
I can see only 3 of them, sir. Yeah, now I can see
all of them here. So Pragati, Shamima, then Danya, Kusuma, and Sasli. So
excellent job, sir. Excellent, very good, very well performed. Very well done.
With sir also. Let me just see if I can have. Yeah, sir is also here.
It was very well done, sir. Nicely, they put in a lot of effort, and all applause to these students. So, and I always believe that if students are themselves a part of the process, so they tend to encourage more students along with them.
So it was really nice that like you joined, and our students also, they also prepared nicely all the material, and we can see that like what all we had introduction to medication error, and then we had again like collaboration between the pharmacovigilance center and the medication error related activities. And I say, like it's another very important area we all can propose to the PVPI to include additional responsibility and also add more resources also. So this in this way, like we can enhance the significance of the AMCs and their work. That is also there. And also, we talked about three important research studies, and then followed by your presentation confirming, because what people should not, shy away saying that, this is only students for this thing. Again, an expert and the senior person coming online and then explaining to everyone. So everything added to the glamour of this program. And again, I would like to say that we started from like introduction to medication error like last 15 days back, and then I assigned all these activities to the students. They went to wards, they went to pharmacy, they learned about the functioning of the pharmacy, they learned about the almost 20, each one were given to, a task to identify 2020 prescribing errors or medication errors and make a tabulation of it. And we will be, like analyzing them. So to analyze them, I have taught them about the, what are the data types, what are the methods to analyze, what are the statistical tools available, and all those things. We had a separate lecture session for that. In addition, continuously we had every day-to-day basis we had discussions on all these aspects, and now we are concluding with this CME.
So, sir, I would just like to add one thing, sir. I have my students also out here. I can see a lot of them, and with your permission, maybe if you agree on this, if my students want to come up with something like this, Sir will be providing you the platform.
Yes, sir, definitely.
So this is an opportunity for all of you to come on a live platform, courtesy Shivamurthy sir, and you'll be able, and I know that you'll be able to do wonderfully if you are.
Yes, sir, definitely. Like we will encourage some more, maybe the same topic or different topic. So,
any topic, sir. Let's see what the students come up. I want to see how students come up with the topics, because if we give them liberty, they have their own innovative ways with coming up with some creative ideas and good ideas, and then they give up a lot of things. They give a whole new meaning to what.
Student CMEs can come. Actually, I think I have seen student conferences are done, but I think this is the first time a student CME on a medication level has been conducted, and the record is created for the first time. Hope that this we can write a editorial also, sir. Wherever if we can write an editorial as a teaching methodology for the including student CMEs as one of the method to and also webinar type. We collaborated with every inter-college webinars also we did. And we will be happy, sir. Actually, I think one center is always better because we can control it. Because inter-college, sometimes complexities will get added also. Because based on the teachers' availability and their time also. So please come up, sir. We will definitely support. And MPS.
No,
yes, sir.
Sir, I give the opportunity to the students. There are, I think I can see around 20, 25 of them. So I give them the opportunity. They can discuss it in their group. And if they want, give us a concrete idea, concrete plan, and then we come up with something. And obviously, if you interact with students of other colleges, you grow. You tend to grow. More interaction means more growth. That is as simple as.
And may I request, all the participants, if any questions are there, they can, even easily come out, or either they can open a mic or they can post it in the comments so that we can read them. Because if everyone opens the mic at a time, there will be disturbances. If any questions are there, they can type. In meanwhile, can I request everyone to, like a video on so that we can take a group photo also. Everyone, please, switch on your video. Whoever is available, please switch on your videos.
Swati
Swati, Acharya.
And Swati ma'am has been very active. Thank you, ma'am, for.
Thank you, madam.
Swati Acharya ma'am. Swati Acharya.
Yes, yes. All of you, please, switch on your mobiles and these videos if possible. And Swati, madam, can you please any comment if you have any comments?
Very well taken initiative, sir. I'm very much happy to see your students, enthusiasm and participation. I think we will also be able to disseminate same kind of activities in our colleges.
Okay, thank you so much. And then Tulsi Madhuri is there online. Dr. Tulsi Madhuri, if you want to talk.
We are from Geetham Institute of Medical Sciences and Research, Visakhapatnam.
Okay, madam.
A very nice initiative, sir. Taking it in an online platform is very good initiative. We are doing it in our college, but knowing it to others is very nice.
Yeah. Thank you so much. If anyone else want to comment, you can open your mic and then please comment. And we have actually 5 more minutes are there. So if any comments or any questions, we can take it. So otherwise, we are done for the day. If no more questions are there, so can we end the call if all of you permit? Thank you everyone.
Thank you.
Good day. Good day.
Thank you.
Thank you.
Yeah. So can we take a photo? All of you can just take one.
I'm taking.
One of the
So can you?
yeah.
Yes.
Now they are all here. Now they are all here.
Thank you. Good day, sir.
Good day, sir.
Thank you, sir.
All the
Thank you,
best.
sir.
Thank you.
Good night. We will take photo. Hey, come in, friend. Thank you, sir.